Hi guys, Dr. Gillard here. It is Thursday, week 7, spring of 2021. Here we go. We started talking about cardiac tamponade, so let's keep working on that. What is it? Just as a review, it occurs when a fluid buildup occurs within the pericardial cavity. Pericardial cavity, of course, surrounds the heart, and if the fluid buildup is fast enough, it can crush the heart. And that's cardiac tamponade, when it squeezes the heart and doesn't let enough blood come out of the heart because of that. What's the result of that? What's the clinical signs of cardiac tamponade? Well, if you're not getting enough blood coming out of the heart, you're going to get cyanosis, dyspnea, syncope, dizziness, and then you could eventually go into shock and die if it's not drained. All right. Where does it come from? How do you get cardiac tamponade? Well, pericarditis is one fairly common way. We talked about that last time as well, but remember pericarditis, don't know why it doesn't remember that. It's an inflammation of the serous pericardium, and when the serous cells get irritated, they overproduce serous fluid. And that fluid will accumulate within the pericardial cavity. And once you get over 50 milliliters of serous pericardial fluid, you're on your way to cardiac tamponade. You won't be symptomatic yet, but once you get to about 200 milliliters of fluid in that pericardial cavity, it'll crush your heart, and you'll start knowing symptoms, dizziness, and out of breath walking up the stairs, and signs of hypoxia in general. Yep. And if it comes on very slowly over time, remember we said the fibrous pericardium can slowly adapt to increase fluid. But if it comes on fast, the fibrous pericardium is very unforgiving, and it'll crush the heart. How about some more causes of cardiac tamponade? Well, you can get a pus buildup if it's a really bad infection. The infection juices can produce pus. So that can start to accumulate, and that's called a pyopericardium. Pyo meaning kind of a pus-filled pericardial cavity. Blood is a common one. We talked in depth about how Stanford A, DeBakey 1, DeBakey 2 aneurysms, if they rupture at the root of the aorta, they can fill the pericardial cavity up with blood. And that's called a hemopericardium. Hemopericardium. That can also occur with a penetrating injury to the heart. A superficial myocardial infarction can result in blood leaking out of it into the pericardial cavity as well. And then a concussion injury when you're in a head-on accident or rear-end accident, where the heart takes a concussion force and rips some of the blood vessels and bleeds. Those all cause hemopericardiums. And if it gets big enough, it causes cardiac tamponade. You can even get a pneumopericardium, kind of like a pneumothorax, which is the same kind of deal around in the pleural cavity. But pneumopericardium from a penetrating injury or blunt trauma as well. You can rupture the lung and the heart together, and the leaking lung air can get into the pericardial cavity. Or if you have a stab wound, air can get into the pericardial cavity like that, if it's just right. Here's a 48-year-old male who comes in the emergency room with crushing chest pain, dyspnea, he can't breathe, emergency CT scan is performed. This is an axial view. There you can see the thoracic vertebrae right through the heart, and sure enough, you can see blood, a ring around the heart. So that blood is in the pericardial cavity, or in the pericardial cavity. Remember what makes up the pericardial cavity? It's between the serous it's between the parietal and visceral layers of the serous pericardia. And we talked about that, but yep, there you see a real picture of one. How about more causes of cardiac tamponade? Well, pretty much the same as pericarditis, because pericarditis is the general cause of it. But what can cause pericarditis? Metastatic disease, you get cancer cells in there, and those can start an infection. or an inflammation process. Uremic pericarditis, we talked about how dying a kidney can release products and waste into the blood, and plus it refuses to process nitrogen-based products. So nitrogen-based products like urea in particular circulate in the blood, and they can get stuck in the pericardium and invoke a autoimmune attack against them, or just a flat-out inflammatory attack against them. Urea is not supposed to be in the pericardial cavity. Autoimmune disease, some unknown environmental toxin could get stuck in the pericardium and spark an inflammation. We just said uremic pericarditis can kind of do it. And unknown causes. Is cardiac tamponade a systolic problem or a diastolic problem? Well, the heart is being squeezed, but remember when the heart contracts, unlike your bicep, which grows in size when you contract it, when your heart contracts, it gets narrower, the circumference decreases. And so when the circumference decreases, the pericardial cavity just clamps down on it and won't let it re-expand. So the heart can't re-expand. So it is actually a problem with diastole. Systole is a contraction force, and it doesn't have any problem doing that, but it can't fill, and that's the problem. If you can't fill the heart, there goes your stroke volume, and that's no good, right? You can speed up the heart a little bit to offset the output of the blood coming out of the heart. You can speed it up a little bit, not that much. So just diminished stroke volume will all lead to hypovolemia and hypertension. Classic sequelae of tamponade, decreased ventricular filling leads to decreased stroke volume. Decreased stroke volume leads to signs of hypotension, hypoxia, and shock, just like we said. Other signs include dyspnea, dyspnea on exertion, tachycardia, tachypnea, cyanosis. Some more sequelae. So the hypotension may ultimately be bad, right? Lead to hypovolemic shock and death. Elevated renal levels will also be positive because the hypotension will turn on the R2A system. So this is very bad stuff. Right, here's a patient who had a slow pericardial effusion because of metastatic disease from the lung cancer that spread to the pericardium and slowly increased fluid around the heart. And the fibrous pericardium can respond to pressure to expand as long as it's slow. And look at how big. That's ridiculously big, isn't it? They stuck a needle in the pericardial cavity and sucked the fluid out, and lo and behold, 2.5 liters of fluid, which is a crazy amount of fluid. Clinical findings. Well, what happens if you put your stethoscope over someone who has a heart all swelled up with fluid? It's going to be quiet, so you get this small, quiet heart sign. Because the fluid just muffles the sounds of the heart and you can't hear through that. You also get something called Pulsus paradoxus, which can be very prevalent in these cases. In fact, that's a warning sign. And Kussmaul's sign will be absent. And I don't think you guys know what those are, so we better go into a rabbit hole and talk about them. Pulsus paradoxus was actually discovered by Kussmaul way back in the 1800s. And he had a patient with cardiac tamponade, and he noticed a weird paradox when examining the patient. When he was simply palpating the radial pulse, he noticed that the radial pulse would stop every time the patient took a breath in. And when the patient expired or blew the air out, the pulse would come back. He's like, what the heck? That doesn't make sense. And then he auscultated the patient to see if the heart stopped during inspiration, and the heart was fine. So how can the pulse stop but the heart keep beating? So that was the conundrum back in those days. And so weird paradox. So let's explain it. How can this happen? So in general, we know that when you take a deep breath in, it creates a very strong negative pressure within the thoracic cavity, a sucking force, and that sucks blood or encourages blood to flow into the right side of the heart. and that's what it is. And so normally what happens when you do this, let's everybody take a deep breath right now. Take a breath in. Okay, now I could have had you palpate your pulse, and your pulse is not going to disappear. Why is that? Well, because when you suck blood into the right side of your heart, you have plenty of room for that heart to stretch out. There's nothing strangling the heart, is there? And so the right heart, when I say right heart, I mean the right atrium, right ventricles. It can stretch way out. And that's exactly what happens. But now we see a problem if your pericardium is all filled up with fluid and you can't stretch your heart out. What's going to happen? And that's exactly the problem here. So the pathophysiology is in cardiac tamponade, the fluid squeezes down on the heart. And you can't expand, and there's nowhere for the blood to go. But it's got to go somewhere. So where does it go? It actually pushes in to the left ventricle through the interventricular septum. The right ventricle fills up with blood, and it tries to go out, and it can't. But it can push that interventricular septum over, and therefore you can accommodate the blood. But that's not good, right, to squish the left ventricle, because now we're going to have a filling problem. We can't fill the left ventricle with blood. We're not going to eject much blood out of the heart. And yeah, so everything I said, interventricular septum, there's nowhere to go. It decreases the left ventricular volume, therefore it decreases the stroke volume. And decreased stroke volume gives decreased blood pressure. But this is only during inspiration, right? See how that works? So that leads to Pulsus paradoxus. Let's look at a picture here. It will help us. So normally, here is a heart. Here's the chambers. Here's the right heart. Here's the left heart. There's the right ventricle. There's the left ventricle. And during inspiration, you suck blood. More blood comes in to the right ventricle and right atria. But you just expand. The right heart is stretchy, so you just kind of blow this area out. No big deal. But if you have fluid in the pericardium, the pericardial cavity, like this green stuff, and you take a deep breath, the blood comes in and it can't push the wall out. Instead, look what's happened to the interventricular septum. And look at the size of the left ventricle, right? Compare that to here. So you can see during inspiration what's going to happen to the pulse on this beat, the next few beats of the heart. You're not going to have your pulse is going to be like 40. So it'll be to the point where you can't palpate the pulse. See how that works? But once you expire and you're not sucking extra blood in here, everything will be just fine. Got it? The official definition is a drop in systole by 10 millimeters or more during normal inspiration, as measured by sphygmomanometry. That's a mouthful, isn't it? Sphygmomanometry. Well, how do you know? So how do you test for Pulsus paradoxus is the next question. Well, let's go through it. I keep saying I'm going to put this in lab, and one of these days, maybe next quarter, this is going in, because this would be handy to know how to test for this. So put on the blood pressure cuff on the patient, and tell the patient to they can keep breathing, but don't have them breathe. Just have them breathe a little bit shallower than normal, because you don't want them sucking a lot of blood in when this is going on, when you're starting this procedure. All right, so put the cuff on, and you want to find the cutoff pressure. So put your fingers on the brachial artery and pump up the blood pressure cuff. Pump, pump, pump. Can you feel the brachial pulse? If you're taking it where I teach you to take it, you can feel it for sure. And then when you get up to about, let's say it's 120. Go up 30 millimeters higher, and that's where you're going to start to auscultate. All right, so pump it up to 30 millimeters higher, so that would be up to 150. Now get your stethoscope out, put the diaphragm down where the brachial pulse is, and you're still held up there at about 150. Now slowly let the valve out and go back down, because you already know you're going to hear it about 120 again, but you just want to make sure you didn't fall into an auscultatory gap. So get ready. You're coming down 140, 130. And then let's say at 130, you heard boom. That's Karate cough 1. Okay, so you know systole. Go down 10 millimeters of mercury further. So go down to 120 and then shut the valve. Stop it right there. You're not going to let any more air out. You're going to hang out at 120. And you're just going to listen. Now tell the patient, okay, you can breathe a little more deeply now. And see what happens when they breathe in. If nothing happens, they don't have pulsus paradoxus. But if all of a sudden the pulse disappears, or the auscultatory sounds, we're in Karate cough 2 now, so Karate cough 2 sounds disappear, they have pulsus paradoxus. You could even take it down another 10, go down to 110, and stop it there and listen. You can kind of gauge how severe it is by going down. But 10 millimeters makes the diagnosis. Okay, so see how that works? So you can read about it. All right. Now there's another weird phenomenon with pulsus paradoxus. They notice that patients with COPD, especially chronic emphysema, remember COPD is a combination of chronic bronchitis and chronic emphysema. They noticed that patients with COPD also had this weird pulsus paradoxus. So what's the story with that? Well, we know patients with COPD, the circulation is destroyed. And the right heart has a really tough time pumping blood through the microcirculation of the lungs, right? We also know, or you should know from physiology, that when you take a deep breath, the lungs tend to hang on to the blood. They're stingy about letting the blood go. So when you take a deep breath, the blood returning to the left atrium, and which ultimately gets in the left ventricle, it's a little bit shy of what it normally is. So that phenomenon is exacerbated with pulsus paradoxus. So inspiration really makes it hard for blood to leave the lungs, and therefore you get an underfilling of the left atrium in people with COPD. All right, so that's COPD is another way that you can have a pulsus paradoxus. Why? Because it makes it very hard for blood not only to be pushed through the lungs, but it makes it hard for blood to leave the lungs on top of that. Right? So yep, everything I said. What are the causes of pulsus paradoxus then? The causes of pulsus paradoxus. To recap, the most common cause is cardiac tamponade, and it's usually from infectious pericarditis. Another cause, as we just said, is COPD, which is chronic emphysemic bronchitis, and somewhat more and more authors are including chronic asthma under the category of COPD. All right, now we have Kussmaul sign, and this is where it gets a little more confusing, but not really the way I explain it, I don't think. So think of Kussmaul sign is a more severe strangulation of the heart. It's just a severe beaver dam in the heart, in the right heart, or a beaver dam somewhere in the lungs. All right, and it's, so just think that. And so with the severe beaver dam, or the severe strangulation of the heart, it's so bad that not only does the patient have pulsus paradoxus, but they also, when they take a deep breath in, they also get a bugging out or a poking out of the external jugular vein. The external jugular vein bulges out when they take a deep breath. That's Kussmaul sign. Right? So definition occurs when the external jugular vein Distension fails to diminish. Normally, if we put you up at 15, 30 degrees on an incline, in a supine position, and normally your external jugular pops out a tiny bit in that position. If we had you take a deep breath in, the opposite's supposed to happen. This is supposed to disappear because you're sucking this blood into the right heart. But people with a roadblock in the right heart, it can't get in. And in fact, paradoxically, it might even get bigger instead of smaller. So that's a Kussmaul sign. That was discovered by Kussmaul too. The cause of this is a little bit more mysterious, but in general, the patients, again, will have a concomitant pulsus paradoxus, meaning they usually, but not always, strangely, some patients have a Kussmaul sign without pulsus paradoxus, but it's not the norm. So maybe it's best not to think about that. But what are the etiologies that cause Kussmaul sign? Well, again, it's something that strangles the heart more severely than cardiac tamponade. What could strangle the heart more severely than fluid in the pericardial cavity? Well, how about scar tissue in the pericardial cavity? And that's exactly what happens in constrictive pericarditis, which I think we'll take a peek at in a little bit. Okay, so it starts, well, I won't spoil it. It's basically the pericardial cavity is filled up with thick, tenacious scar tissue, so it gets strangled more. Another condition called restrictive cardiomyopathy, where the beaver dam is not the pericardial cavity, but it's actually the myocardium of the heart itself, has gotten so scarred up, so fibrotic, that when you take a breath and suck blood into your heart, it won't expand because it just can't expand because it's got all scar tissue in it. Kussmaul sign, the two most common causes of Kussmaul sign, again, constrictive pericarditis. The cause in about 33% of patients with Kussmaul sign. Again, it's a thick, tenacious scar tissue that's built up in the pericardial cavity, and it strangles the heart to the point that no expansion can occur. So the ventricles won't expand at all. So where does the incoming blood go? Because when you create a negative pressure in the thorax, blood is going to suck into the heart. So where does that blood go? Well, the first of the blood that gets into the heart will push the the interventricular septum into the left ventricle and create a pulsus paradoxus. But there's still more blood coming in and there's no room for it. So it can't get into the heart, so instead it just backs up. It backs up into like a beaver dam. It backs up upstream. Where's upstream? The external carotid, or the external jugular vein, will bug out, and then the liver will swell with blood as well. Now you can't see that, but you can palpate that sometimes. See how that works? And then the other one is restrictive cardiomyopathy. We said it's the myocardium becomes very thick and scarred up, to the point it just won't expand. And what can scar up and cause fibrosis of the myocardium? Sarcoidosis, hematochromatosis, amyloidosis are classic for doing this. And pulsus paradoxus is usually present. There's a classic table from Johnson. And so constrictive pericarditis, patients with constrictive pericarditis have a positive pulsus paradoxus and a positive Kussmaul sign. Patient with restrictive cardiomyopathy, Kussmaul sign, paradoxus. Patients with cardiac tamponade, aka pericardial tamponade, they have pulsus paradoxus, but they don't have Kussmaul sign. So there's the question. Don't miss that. How about another cause of Kussmaul sign? Oh, there's the beaver. If you get a beaver dam, a beaver dam inside the heart, like a big tumor in the right ventricle, that could do it. If you have pulmonary hypertension in the lungs, that can do it. Anything where you can't get blood into the heart when you take a deep breath, and when you suck extra blood into the heart, you can't get any more blood in there. And so that will force blood out of the heart and into the jugular veins and into the liver. Pulmonary embolism that got stuck in the AV orifice, let's say the right AV orifice. Tricuspid stenosis, pulmonic valve stenosis. Any type of beaver dam there can also cause a Kussmaul sign. What's the mechanism? We already said. You suck blood into the right heart. It can't go anywhere. And it pushes the left interventricular septum. Well, there's only one. It pushes the interventricular septum into the left ventricle, which decreases the volume of the left ventricle, and you get pulsus paradoxus. Then there's still more blood coming in. It can't get into the heart at all, so it backs up into the superior vena cava and goes down into the inferior vena cava. The superior vena cava ultimately gives rise to the jugular veins, and we see them bug out, and the liver swells up. Okay, so how can you test to see if the liver is swollen with blood? In addition, maybe you can see Kussmaul sign in a patient, but you want to know if the liver is, what's going on with that. Is that full of blood as well? You can poke your fingers into the liver and see what happens. And that's called the hepatojugular reflex test. So it's a test to confirm the diagnosis of Kussmaul sign. So you put the patient about 30 degrees supine on an inclined bench, push your fingers under the right costal margin and into the liver, and push in there and hold. And then have the patient take a deep breath if you want to intensify this effect, and watch what happens to the jugular vein. Normally, if you did this on a normal person, the pushing and squeezing of the liver would force blood into the heart. But the pericardium would expand and handle that no problem. But in a patient with pulmonary embolism, with COPD, pulmonary hypertension, all those things we talked about, or a failing right ventricle, that could do it as well. The blood can't get into the heart, so it goes up and blows out the jugular vein, so the jugular vein bugs out. Okay, so that's exactly what we talked about. Causes for a positive test usually is right heart failure from COPD, from pulmonary hypertension. Even left heart failure can do it. And then blockage problems of the right heart, the pulmonary trunk, the pulmonary arteries, the lung microcirculation, a beaver dam somewhere. All right, so here's a patient who has this, and they did the hepatojugular reflex test and pushed the fingers in there, and the external jugular popped open and bugged out like crazy. Okay, this patient has right heart failure from COPD. There's another patient. Their head and nose are up here. You can see that. This patient had constrictive pericarditis. What's going on with this one? They're performing the hepatojugular reflex test on her. Well, it's bugging out for sure. See something else bad? Oh yeah, submandibular lymph node. You guys did terrible on the test on this. Is this lymphangiitis, lymphadenopathy, or is it lymphangiitis? What is this? This is a swollen lymph node. That's adenopathy, lymphadenopathy. If this was red, where if the inflammation inside this node got into the skin, you could call that lymphadenitis. If we saw a long, it would be red. I guess I can make it red, can't I? If we saw a long red streak like that, well, that's angie. That's a vessel. Vessels are called angie. That's lymphangiitis. Guys did terrible on that on the test. Treatment, you drain it. You do a procedure called pericardiocentesis, guided by ultrasound, and you stick a big needle into the pericardial cavity, and you drain that juice out. Let's talk a little bit about constrictive pericarditis. That is one of the causes of Kussmaul sign. It's a wicked strangling of the heart, causes cardiac tamponade, and it starts out as an inflammation, but it progresses. Normally, when you have fluid in the pericardial cavity, the fluid is reabsorbed by the body within a couple weeks. But in some patients, that fluid never gets reabsorbed and it basically turns into scar tissue. Fibroblasts come into the area and lay down tons of collagen, and that's basically scar tissue. And yeah, it strangles the heart, and you get cardiac tamponade from that. And as it progresses, it gets, you slowly get dyspnea. Pretty soon you can't walk up the stairs. Pretty soon you just start having trouble breathing, sitting around, because your heart is getting strangled and your stroke volume is decreased, and you're not getting enough blood to the body. It makes up about 0.01% of hospital admissions, so it's fairly rare. It's quite rare, actually. What are the causes of this constrictive pericarditis? It could be, as I just described, the most common type or cause of it is a long-term complication of acute pericarditis, seen in about 9% of patients who develop acute pericarditis. It goes into this kind of chronic pericarditis, if you will, which is called constrictive pericarditis. It tends to occur, oops, sorry, hit my mic there. It tends to occur months or years following a pericarditis, usually an idiopathic one or a viral one. Tuberculosis is a major cause, more in third world countries though. Tuberculosis is a monster. It loves the pericardial cavity. It can get in there and spark a wicked inflammation that's fibroblast heavy, causes all this scarring. And then in the West, in the industrial society, it happens. We don't know. Oftentimes they try to culture it, and it's just full of scar tissue, but we don't know the cause. Could be autoimmune, but they can't find any autoantibodies to it. So we don't know what it is. Maybe a virus. Who knows? Patient who died from it didn't get into the ER in time, and you can see this is the pericardial cavity. I mean, we can't see the pericardial cavity. It's like a millimeter thick. This is like, geez, what is that? 2 centimeters, 3, 4, 5 centimeters? It's ridiculously thick, and it strangled the heart of this person. That's constrictive pericarditis. And what's the fix? Well, you just take off the pericardium. You don't need a pericardium to stay alive. You can remove that. You're going to lose the vagus nerve. Probably need a pacemaker because of this, but you can take it out. Okay, that's it. Now we're starting a very tough subject called EKG or ECG. And this is where people have trouble. So now I took out I had a big, long, probably 2 lectures preparing you for this, and I just don't have time to do that anymore. So go to YouTube and search Dr. Gillard cardiac conduction, and my video will pop up, and you can go through the lecture if you need to understand the cardiac conduction and how the SA node sends a wave of depolarization, and it goes into the AV node and goes into the bundle of His, and then right and left bundles, and we'll talk all about that in the video. But I do want you to know the pathway. So as I said, the SA node sends out a wave of depolarization. It sends that out. You guys usually don't know what Bachmann's bundle is. It's a superhighway. It's incredibly fast. It's so fast that when you have a spontaneous depolarization of the SA node, it's so fast that it's almost like you have 2 SA nodes. The signal just flies so fast over to the left. And then the left atria, the wave of depolarization sweeps over that. Everybody's heading toward the AV node, right? And then out of the SA node, it goes through these internodal pathways, which aren't that fast. And they're slow enough that about the same time, all these signals start hitting this AV node, right? And then what happens in the AV node? That is so important. This thing saves people. People with atrial fibrillation, they would not be here with us if this AV node wasn't working. Although the bundle of His has a little slowdown function too. But this is the slower downer, right? When a signal comes into the AV node, it's stopped for a minute. And that why does it get stopped? What's the deal with that? Why do you need to stop it? Well, you need to give the we have a wave of electricity going over the atria here. We need to give the atria time to contract, to squeeze blood into the ventricles. We don't want the ventricles to start contracting before they're packed with blood. So it gives time, atrial systole, gives time for the atria to squeeze blood into the ventricles. That's why the slowdown portion is there. Right. All right. So AV node, we said, super important. That slowdown has a name. It's called decremental conduction. Decremental conduction, and everything I just said already allows for the ventricles to be completely filled up, and it'll save your life with people, as we'll talk about when the time comes. Okay, ECG, electrocardiogram, also called, some people call it EKG out of respect for Einthoven, who discovered most of this. I put this part of the course together from scratch. Here's the books I used. My notes are good enough. You don't need to buy any of these. If you had to buy one of them, which one would you buy? I would buy Thaler here. It's maybe not quite deep enough, but it's a very, very popular book. Medical schools use this one a lot. The best one, though, is this Garcia book, which is out of print. You can still find it on eBay, and you can still find copies of it. It's a fabulous book. Garcia, Thomas Garcia, he's written books since this one. I want to say it's 2006 is the publication date of this. He's written subsequent books, and they're not as good. I don't know what happened, but they're not nearly as good. This is an awesome book. I like Shu, I guess that's pronounced Shu. That's too deep for you guys to start with, but I would like to get into that. And ISA is also a good book as well. All right, so EKG, also called ECG, also called a tracing. If you don't know that word, a EKG tracing or a ECG tracing, developed by Einthoven way back in the 1900s. It is the most requested routine test in medicine, period. Super common. Primary docs, many of them have this right in their own office. Some do, some don't. The machines are so good. They'll catch most arrhythmias, and so you don't. I mean, I'm not saying to just buy one of these. You should be. You need to know how to read these yourself. And I'm going to teach you. We're just scratching the surface. I've taken a lot of the stuff out because I could literally teach this whole 5-hour-a-week course on EKG to get you up to speed. But my goal is to get you up to the level of a nurse. My daughter's a RN, and she's went through this, and you'll know about it as much as she does, and I think that's a good enough for you guys to know. Yep, so super important tool. It's considered the gold standard for diagnosing heart arrhythmias. It's really good at picking out myocardial infarctions. And what is it? It's just a recording of the electrical activity of the heart. And these machines, I haven't checked. It's been a year. It'll be interesting to see what the prices are now. But last year I checked, and you could get a really good machine for about $1,400, which is a complete tax write-off, right? Instead of paying Uncle Sam for that, you just write it off. So, what does it look like, or what does it do? Well, we said it measures the average flow of electricity through the heart. So that's what it does. And so why do we care about the average flow? And it tells us the direction, not only the average flow, but it tells us the average direction of flow in accord with this little system we'll look at here in a second. You got to measure it against something, but certain diseases of the heart will, like a myocardial infarction, they make predictable changes in this average flow of current through the heart. And that's kind of the basis of that. What can be gained? Well, by looking at the EKG, we can learn things about the heart's level of mechanical function. Are the valves working right? What's the size of the heart? Is this its normal size? What's the level of perfusion of the heart? Heart's electrical system, is that working right? Is there a bundle branch block? There's a lot that can be learned from this thing. Even pericarditis, it can detect pericarditis. How can this possibly work? How can we get electrical reading of the heart? There's nothing over your sternum. There's nothing there. There's just a little fat. There's ribs and fat and some tissue, but there's nothing that stops us from listening or tapping into the electrical flow of the heart. So that's how that works. And if you strategically place these electrodes around the heart, you can capture the flow of current through the heart. And that flow of current through the heart is called an ECG or EKG. All right. Nowadays it's all put on a little hard drive, but you still, when you go to the ER, you'll still give you a printout that'll be floating around the room. There's EKG paper that the heart's electrical activity is placed upon. Right? What data does it give you? There's a x-axis and a y-axis, and the machine will draw the different, in 12 leads, you get 12 different looks of the flow of current that can be drawn in relation to this x and y axis. So lots of stuff. You got to know this, or you're going to have trouble passing this last test. And I think Dr. Dole's already got you with this stuff. So there's little red boxes and big red boxes. Where's the EKG paper? See the big red boxes? So lots of big red boxes, tiny little red boxes. So what do we know about those? They're actually 1 by 1 millimeters, so it's really simple. There's 5 of them across, 5 of them in the x-axis, 5 of them in the y-axis. Okay. The millimeters isn't really what we look at, though. This axis is time. This axis going up. The y-axis is voltage. So the one we really look at is time. Each as the current is charted against time, each little box is 0.04 seconds. So one little box, 0.04. 1 times 2, or 0.04 times 2 is 0.08. So 2 little boxes is 0.08 seconds in time. 3 little boxes is 0.12 seconds in time. See how that works? And then voltage is on the other way. Well, let's look at this first. So we have, I'm sorry, I don't know if you can hear the kids screaming, and it's kitty hour outside. So here's 2 little boxes. So each one of these little boxes is 0.04. So 0.04 plus 0.04 is 0.08. There's 4 little boxes is 0.16. And you get the deal, right? 1 second is 5 big boxes. Right? And then voltage is not important. We're not going to talk much about that. Just a little bit about it. 1 little box is 0.1 millivolts. So this is really simple. So 5 little boxes is 1 millivolt. All right, so 2 millivolts. Okay, that's not super important to us, though. What about the surface anatomy? So of the heart. So the anterior surface of the heart really represents the right ventricle. This is just basic anatomy. Posterior surface is the left ventricle. That's the one where people get messed up. Remember, the left ventricle is basically, it's off to the left a little bit, but it's basically behind the right ventricle. The inferior surface of the heart is made up of mainly left ventricle. The left lateral surface, mainly left ventricle. If we look at this now, you have to imagine a little bit here on this heart. But here's the heart coming out of the plane of the page. Going deep into the plane of the page. This is out of the plane of the page. This is the bottom of the heart. This is the posterior part of the heart, and it's mainly left ventricle, or left atrium. Right atrium is over here a bit, but if I can draw the right atrium would extend about like this. See how they're overlapped like that? only it's more into the plane of the page. All right. The concept of the angle of orientation. So we're going to set up 12 cameras around the heart, and we're going to watch electricity flow through the heart. And each camera has a different look. And those looks, or the view that the camera has a name. And that's called the angle of orientation. The angle of orientation. I'm not so going to test you on setting this thing up, but it's a 12 lead EKG is what is always used. There's 10 physical leads. There's 2 additional leads that are made by the machine is able to flip polarities and create 2 additional views. And the leads should be about 10 centimeters away from the heart. You don't have to put some of your leads all the way down on your ankles and down on your wrists. As long as they're 10 centimeters away from the heart, you're okay. So the limb leads, you can put them here. You don't have to put them. I've had lots of EKGs, and I say, why are you putting them? Some don't do them. Some put them right here. They're modernized, but some of the older nurses will put them way down on my wrist. I'm like, you know you don't have to do that, right? Oh, you have to do that. I said, no, you don't. You put them right up here as long as they're 10 centimeters. I teach this stuff. So you don't have to put them way down there. Anyway, so those are the limb leads, the ones in blue. And these are the chest leads that go across like this. And we'll look more specifically next time at these. There are 2 main categories of leads. There's 6 limb leads and there's 6 precordial leads. Limb leads are sometimes called standard leads or standard limb leads. Precordial leads are often called chest leads. And and they all have different angles of orientation. We'll talk about first just the limb leads. The limb leads are in a coronal plane is their angle of orientation, but their camera is set up on the perimeter. So you would have a camera looking like this, but its view is parallel to this coronal plane. See how that works? And we got limb lead 2 down here. It's still they're sliding along this coronal plane. On the other side of the coin, we have the chest leads, and the chest leads are looking at from an outside of an axial plane. Some chest leads will, for example, be like chest lead 4. It looks right down in the septum, interventricular septum. But they're looking in the horizontal plane, if that makes sense to you. All right, the 6 limb leads, again, everything I just said. They look from the perimeter of a frontal plane, basically from eye to ass or lateral to medial. And they're parallel to that coronal plane. They're in the plane of a coronal plane. And they see the average electrical activity of the heart in 3 different views, basically inferior views, left lateral views, and right lateral view. There's actually only one that's over on the right side. All right, now we can split the 6 limb leads up into 2 different divisions, the standard limb leads and the augmented limb leads. All right, and that's all we'll say. The 3 standard limb leads, that's the one you probably did back in first quarter. You probably set up an old Einthoven's triangle type deal, and you can look at them, and they're important. Some of those leads, limb lead 2 is still to this day is one of the most important of all the 12 limb leads. There's also 3 augmented leads that are made by the computer. These are computer generated leads, and they're important as well, especially one called AVR, because that gives us a view from the right side lateral to medial. We see a view of the current flowing away from us from that lead. All right, so this thing, I can't get any more stars on here. You need to memorize this to play the game. To answer test questions, can you pass the test? I'm not sure you can pass the test without knowing this. So I said that the current flows through the chest. Like say we have a flow Usually the current flows like that through the ventricles toward the southeast. But we have to have something to quantify that flow. So we have this hexaxial reference system. Hexaxial reference system. I like to call it the angle of orientation wheel. But whatever you want to call it, or the AOO wheel, whatever you want to call it, you need to know. So 0 degrees is if we set this up like a compass, 0 degrees would be to the east. Okay? To the south, we have plus 90 degrees. We have negative 90 degrees to the north. Right? And then we have negative 180 degrees to the west. And then every 30 degrees, we have another interval. The key point here is when we go towards the south from the east, or once we get below this east to west line, the degrees are positive until you hit west. If you go from east to north, the degrees are negative. So for example, AVL, which is a limb lead, an augmented lead we'll look at next time. That's its angle of orientation is negative 30 degrees. And this will make more sense. I think Dr. Doe went over this a little bit. Memorize this wheel, right? If those of you who will memorize this wheel, because remember, we're testing in person now, so it's not, this is not an open note test like it has been for the last year or so. So you better start memorizing this stuff. All right, angle of orientation, we already said that is the camera's eye, the camera's view of how and it watches the heart, and that's just the camera's view of the current flowing through the heart. So there's 12 different angles of orientation. And I'm not going to test you on this, but there's a positive lead and a negative lead. These are positive leads. Is the actual angle of orientation. What is recorded? We have a flow of current, but it's actually the average flow of current. Current as it flows through the heart goes all different directions. It swirls chaotically. But the EKG equipment can smooth out. The computer smooths out and gives us a steady direction. Actually, here's an example of that. In reality, when for a heartbeat, the current is going all over the place. But the EKG smooths it out. And for ventricles, the average current flow is right toward the south, or the east, toward the southeast, basically, toward the left pocket. Okay, another very important word you should memorize if you don't know it already is called the mean electrical axis, or the MEA. There's a whole bunch of AKAs. The vector of depolarization, the vector, the QRS vector, the vector of current flow, the axis of the heart. When books will talk about the axis of the heart, that's just the mean electrical axis. That's the average flow of current through the heart. It's this thing right here. That's the axis. Got it? All right, that's it. Send me those email questions. See you later.